you very much, Mr. Chairman. Good afternoon here again. I think I will not repeat the data again, but I will stress probably on the pathogenesis of the disease and how to select probably the second line or the third line treatment, and how to tailor the treatment and make our selection. So I will go through the data which already has been presented fastly. Now, the pathogenesis of renal cell carcinoma, as you all know, this is the Hanahan diagram which has been published in 2000s. It shows you that there is many drivers for any type of cancer, and there are many targets that can target these drivers. So the issue is how to identify these drivers for each type of cancer in order to target them, and whether you can have two drivers at the same time, or whenever you block certain driver, you can have or promote the other driver for certain tumors. As you all know, that angiogenesis is one of these drivers. Also, escape mechanisms with immunotherapy is another driver, and there are many others in the cascade. The vascular endothelial growth factor receptors was the first target identified in renal cell carcinoma, and this made the revolution on the treatment of renal cell cancer. As you all know, the tumors grow without any vascularity till the size of 1 centimeter or 10 millimeters. And in order to progress and increase beyond that size, it needs their own neovascularization or blood vessels. And this neovascularization starts initiated by the angiogenesis, which is secondary to the secretion of promoters from the tumor itself. And whenever you establish this neovascularization, the tumor can grow, progress, and metastasize. In the model of renal cell carcinoma, the bone haploidentical mutation is very frequently, whether it is in the germline or somatic, and this will lead to the overexpression of hypoxia-inducing factor. The hypoxia-inducing factor will stimulate the angiogenesis and will form the tumor. So inhibiting this process directly by the tyrosine kinase inhibitors may inhibit that process and prevent these promoters, or indirectly by the mTOR, which also interact with the hypoxia-inducing factor by promoting the overexpression. If you take the tumor type and you see the vascular endothelial growth factors overexpression, we see renal cell carcinoma that's like 100% overexpressed. And one of the main drivers of the renal cell carcinoma are the vascular endothelial growth factors pathways. And this is our diagram. These are preclinical diagrams showing that the tumor can be inhibited with angiogenesis, and you see the shrinkage of the tumor or the inhibition of the neovascularization, and how the tumor can shrink if you use these treatments. Another modality of the treatment is the escape mechanisms. And this is applied in general for all the tumor. It is not has been identified in renal cell carcinoma per se, but this is applied in melanoma, in lung cancer, and in renal cell carcinoma for a certain extent. The tumor, usually whenever you have a tumor, that tumor has a certain receptors which can be identified by the immune system as a foreign body. And the T cell recognizes it, and then it secretes enzymes which destroy the tumor and kill the tumor, and this will activate the further T cells. In the tumor cells, they have certain receptors which called the PD-L1, and these PD-L1 stimulate the receptors found in the T cells. And whenever it gets stimulated the T cells, it has an inhibitory effect on the activation of T cell, which lead to the inactivation of T cell and stop the boosting of this immune response. The antibody, the PD-1 and PD-L1 antibodies, these are antibodies developed in order to prevent this inhibitory effect on the immune system, to reboost the immunity to against cancer, and they found in many types of cancer is really successful, and renal cell carcinoma is one of these. The axitinib, as we mentioned, was the first drug which has been VEGF, beyond VEGF progression, after sorafenib approved, and mainly because it is a second generation and the efficacy of inhibition on the VEGFR2 was stronger than the first generation receptors. And as I mentioned earlier, the axitinib or the AXIS trial was the first trial which proved the concept of axitinib superior to sorafenib, which was the standard of care. And this is mainly, again, these are the patient characteristics, and the progression-free survival, which was the primary endpoint, was met, as we mentioned, and mainly after cytokines or sunitinib. This is an effective treatment. And if you see the subgroup analysis, all improved with improvement in the response rate. And if you see that the drug delivery, here is a very important point that if you see that 1/3 of those patients, there was an escalation of the dose, and 1/3 of the patients, there was decrease in the dose. And this is the first concept where we use tyrosine kinase according to dosing for certain patients, but this is mainly taken as a toxicity. We all know that tyrosine kinase inhibitors are given to patients whether they weigh like 30 kilograms or they weigh 100 kilograms. We never look in the AUC level of those drugs and whether there is a correlation with that toxicity or improvement. Most of the cases, whenever the patient experiences certain toxicity, was an indicator that probably we are overdosing these patients and we de-escalate the dose. The AXIS trial was the first trial to address the concept of dosing therapy in this field. So the dose escalation, what is the rationale behind it? The rationale behind it, there was phase 2 studies, included 114 patients. Those patients who progressed on either cytokine refractory disease or sorafenib refractory disease. And they found that if there is a relation between the AUC and the shrinkage of that tumor, they found that for each increase in 100 nanogram per ml in those post cytokines, there is a further shrinkage of the tumor by 1.3 and 1.2% for those post sorafenib. So there was a correlation between the AUC and the response and the shrinkage of that tumor. And this is not only related to the shrink of the tumor, but also the progression of free survival for those patients were improved from 69 weeks to 88 weeks. The other parameters which they found, apart from the AUC level, is the diastolic blood pressure. And they found that the increase in diastolic blood pressure was strongly correlated with the improvement in the progression-free survival. And this is another diagram showing that this improvement, this correlation between diastolic blood pressure and the response and shrinkage of the tumor is not related even to the AUC. Even for those who are below the level of AUC with high diastolic blood pressure, they achieve a good response. So the rationale, there was two rationale. First, the AUC level, and this is correlated to the toxicity, and the diastolic blood pressure is also directed to response rate. And this is where they came with the AXIS criteria in order to modify the dosing. They decided that those patients who receive the axitinib, if they don't experience any toxicity, grade 2 or more, or they have a diastolic blood pressure less than 150/90 without any antihypertensive treatment, they decide to escalate the dose 2-stepwise to 7 milligrams, and then if they have the same, to increase it to 10 milligrams. And these are the diagrams where it showed that 1/3 of those patients, they had to go for escalation of the dose to 7 and 10 milligrams, and if you see the other 1/3, they de-escalate because of the toxicity for that treatment. If you see the AUC for those patients before escalating or de-escalating the dose, the average level is 231, ranging from 42 to 931. And if you take the criteria of diastolic blood pressure or the toxicity, you see the average for those who are escalated are much lower. The average was 160. And for those who tolerate the 2 escalation for 10 milligrams, where subtherapeutic, even the median, the average was 129. With escalation the dose, you see that we achieve the same average for the average population. And if you see those who after the escalation of the dose, they did better with the progression-free survival improvement. the median or the therapeutic AUC level was considered as 150, and if you escalate the dose to 7 or 10, you can achieve the same level or the therapeutic level. And if you see that the toxicity profile for those who were able to escalate the dose was not increased, so the grade of the 3 and 4 toxicity were almost similar to the whole population. In other words, escalating the dose is optimizing the dose of the treatment rather than escalating the dose to achieve a better response or case of more toxicity. And these are all the side effects they experience, whether you escalate the dose or you don't escalate the dose, they have almost similar toxicity profile. We mentioned these data before, the cabozantinib, nivolumab, and nivolumab. We'll go through them fast, and then to see how we can probably select our patient probably according to these data. Meteor was tyrosine kinase inhibitors with a CNET efficacy in addition to the VEGFR inhibitors. And the Meteor trial were randomized to see as a second line or third line therapy to see if against everolimus, if we can improve the overall survival, the progression-free survival as a primary endpoint, or the overall survival as secondary endpoint. And this was met with an improvement from 3.8 to 7.4 and across all subgroup analysis. And it was associated with improvement in overall survival. And if you see that the toxicity was the main concern of that treatment, because it's more toxic than everolimus, and we know that everolimus it is a hard drug to use, and in Meteor the cabozantinib was even more toxic, and if you see the grade 3/4 toxicity was around 10% more than those with everolimus. The second trial, as we mentioned, platinum, it has been approved as a second-line therapy, and this trial was a pure second-line phase 2 trials. They get the FDA approval. The rationale behind it that the combination has a synergistic effect, and the dose limiting was 18 milligrams for nivolumab and 5 milligrams for everolimus. This is the schema of the clinical trials. These are the patient characteristics which were balanced between the 3 arms, the combination and the single agent, nivolumab or everolimus. And you see that most of those patients, they received sunitinib, some of them bazotinib, sorafenib, or others. And again, if you see that most of those patients had to decrease the dose, 71% in the combination and 62% with the nivolumab, they have to go for dose adjustment, while for everolimus around 26%. Primary endpoints was improved with improvement in progression-free survival, and if you see the response rate, probably this is the highest combination affecting a significant improvement in response rate, increasing from everolimus 6% to almost 43% with nivolumab. And this is again, it's a durable response for almost 13 months when you use it in combination. The overall survival was also met with a significant p-value. But again, it was the toxicity concern, because as we know, the tyrosine kinase inhibitors have toxicity, nivolumab, it's a little bit more toxic in combination with everolimus. These are toxic agents. Probably it's limited for those who are fit patients with a good organ function, and where we need a good achievement of a response rate, probably can be an acceptable option. The third one is the immunotherapy. As you all know, the data was very impressive when we randomized nivolumab against everolimus, and they included 821 patients. The clinical trials was not a pure phase, not a pure second-line therapy, because some of those patients included as a third or fourth-line therapy. The baseline characteristic were almost equal between the 2 arms, and the poor risk group around 16%, while most of them were favorable and intermediate risk group. The primary endpoint, which was overall survival, was significantly improved by almost 85 months compared with everolimus. The secondary endpoint did not show any improvement. It was 4.4 with everolimus and 4.6 with nivolumab. And if you see, the only difference in that graph is mainly the day, where you have the durable response for those 20%, which most probably making the difference in the overall survival. If you see the overall response difference between the everolimus and the treatment, the immunotherapy, again, you see those 20% who did the significance in that benefit. PD-L1 was not predicted for a response to the immunotherapy, so it was not really guiding those patients who will benefit from immunotherapy or not. Now, if you see the safety profile, as we mentioned, the safety profile is a safe drug. The grade 3 and 4 toxicity is by far much better than everolimus. It's almost 50% for those who have everolimus. And if you see that the other toxicity profile mainly is fatigue, nausea, pruritus, so most of those are manageable. And there are specific toxicity from the immunotherapy, which is mainly the immune reaction, the hypothyroidism, and skin toxicity. The most important question is how to select the patient for a subsequent line therapy. We know that most of our patients go for tyrosine kinase inhibitors in the first line setting. Some of them, they do respond, some others, they may progress shortly, and that response can be a durable response or short response. So how we can go for a subsequent line of therapy? Do we put all our patients into immunotherapy because we gain that 5 months? Although we know that only 20% of those patients, they gain that benefit. Or we go for another tyrosine kinase inhibitors, which may help or may not help, or we give the combination with high response rate. Now, we have to interpret these data very carefully and how we can sequence these therapy for our patients, and in order to control and have prolonged control of the disease is the main questions, and how to control this disease for the longer duration. These are the two graphs showing the response to the treatment, the progression-free survival and the overall survival. And if you see that the difference in overall survival is very early in the curve, while those 20% are those who are making the difference, and that difference is persist through the whole things. So it is almost, and you see it, the 5% and the difference of 20%. And if you see that those who do not respond and have the benefit of 20%, they do worse in the progressive disease. So the progressive disease in the immunotherapy was much more than those with the everolimus, and the stable disease also were much less than with everolimus. So we have those 20%, how we can select them. These are the important questions. The data we are seeing with the immunotherapy is almost identical with what we saw in the interleukin 20 years back, when we see the overall survival split very early, and this is mainly for those who are durable response in the 10-15%. The main differences here is the toxicity profile. The interleukin is really very toxic, while the immunotherapy, the current immunotherapy, nivolumab, is very favorable drug. It's not that toxic. If we go for the immune therapy in the era before the immunotherapy, we go for the anti-angiogenesis or the mTOR inhibitors. How you can select these patients? This is important. And if you see the data for immunotherapy also, it's very important point here that those who receive angiogenesis for less than 6 months or more than 6 months, they do the same. If they have 1 or more than 2 angiogenesis, the immunotherapy do the same. So regardless if you give 2 lines of therapy, the efficacy of immunotherapy is similar. If the patient progresses shortly after angiogenesis, will do similar if you give immunotherapy. If we go for the era before immunotherapy, angiogenesis versus everolimus, and these are a retrospective analysis included more than 240 patients, you will see that the subgroup analysis, if you split those who responded to the first line therapy, less than 6 months, or less than a year, or more than 2 years, the continuing anti-angiogenesis was better than mTOR inhibitors. And this will tell you that those who responded with a prolonged response to the first-line therapy, these are addictors to the VEGF receptors, and continuing this VEGF receptors inhibitors in another potent drug will probably can be a good strategy before going to immunotherapy, especially if your patient is fit. And this is another data from the ACCESS trial. It shows you that if you take the cut point of 3 months, 6 months, it's not that big difference. But if you take the criteria of 9 months or more, then the response rate into axitinib was much more pronounced than those who have a shorter interval to the first-line therapy. And this is also the month of the first-line therapy of overall response checkpoint. So it will tell you that selecting these patients is based mainly on the first-line therapy. So we go back to the driver of those patients. With the first-line therapy, we are able to identify the driver mutation for that tumor. So some subset of patients are addicted to the VEGF receptors, and going into a subsequent line of VEGF receptors can be helpful to prolong the first and second line therapy before going to the immunotherapy, while those who are shorter progression, they can go for that. Now the concept for these tumors, if those who respond to immunotherapy are different from those who will respond to the angiogenesis, we don't know. If there is an overlapping between these two, or they have the same population who may respond to this group or that group. Or it can be different, that whenever we treat with angiogenesis and then the patient progresses, we are inducing a resistant, and then probably that resistant will be to immunotherapy or the immune escape mechanisms. So there are a lot of questions that should be answered in the subsequent line of therapy, and the answer for the future, probably to overcome this dilemma, is to use the combination of immunotherapy with tyrosine kinase inhibitors rather than guiding those patients in the current way of selection. And these are the clinical trials where we're addressing the combination of immunotherapy with different tyrosine kinase inhibitors, and there are many trials even giving this upfront randomized against sunitinib. What are also the future are just to identify certain biomarkers that can select, probably rather than selecting the behavior of the first-line therapy, is to select who those can respond to VEGF. In immunotherapy, we know that the PD-1 and PD-L1 staining is not helpful in identifying those patients who respond to immunotherapy in the renal cell carcinoma. But there are very important data published in the Nature, and this correlates the mutational load of the tumor with the response to the immunotherapy. And those tumors with high mutational load, they do respond better. And this is more predictive for a response to immune therapy than what we currently have, the PD-L1 staining. And these are studied in non-small cell lung cancer, showing that if you take a mutational load cut point of 200, and then you can predict those who respond very well to that treatment in the green light, while those who are less, they do not respond to the immunotherapy. And these are mainly in non-small cell lung cancer, has been published with a mutational load. So the future load for the immunotherapy to use as a biomarker can be a combination of the PD-L1 tumor infiltration and the mutational load, which have a very promising predictor to respond to immunotherapy. While for the angiogenesis, there are many mutations trying to address this. There are a lot of failure, but these 5 biomarkers can be, they show some promising data into identifying those patients who may respond to tyrosine kinase inhibitors over those who can progress shortly. If we go and see the NCCN guidelines for the second-line therapy, we see that sorafenib, sunitinib, pazopanib has level 2A. So most of the sunitinib, pazopanib used in the first line was sorafenib. Has been proven that there are drugs better than them. Then sirolimus and everolimus also does not have a higher level in the second-line therapy. Mainly it's axitinib, cabozantinib, and nivolumab, and recently the trial, the combination with everolimus. In summary, tyrosine kinase inhibitors is today still the standard of care, and whether you use sunitinib or pazopanib. And we have more data for sunitinib, and the data more supporting the sunitinib because of the non-inferiority data and the long duration of the experience with that drug. And the duration for the first-line therapy, the response to the first-line therapy can be a predictor to select the subsequent line therapy. And I think this is probably the only predictors available for us. And this is a clinical predictor to select whether to go for another line of the tyrosine kinase inhibitors or to go directly to immunotherapy. Immunotherapy is very good and effective treatment. Probably most of the renal cell carcinoma they should try it. In order to get that benefit of that 20%, because we don't have a predictor today. In clinical practice, the first-line therapy is the predictor, so probably a cut point between 9 to 12 months. The longer the duration, probably the probability will be higher for the subsequent tyrosine kinase inhibitors. For immunotherapy, those who progress shortly on the first-line therapy within less than 12 months, or they have aggressive disease that probably may not have another option of treatment or another chance to give another line of therapy, they should go for immunotherapy. After 2 lines of tyrosine kinase inhibitors, probably better to go for immunotherapy, and this appropriate choice for folks. And by this, I finish my presentation.
Thank you very much, Professor Hassan. It's an excellent unmet need lecture that is really guiding us on how to sequence our treatments. So, any questions from the floor?
Take advantage. So, I believe that you are in favor whenever there's a slow progression of the disease, which has been controlled with the TKI, you prefer to go for another TKI before using the immunotherapy, the evolving method.
I think you see it in most of type of cancer. Those tumors who are driven by a certain type, if you see like in breast cancer, trastuzumab, who responded very well, always that tumor is driven by this pathway. Renal cell carcinoma, sometimes those patients who respond very well and for a longer duration, every time you give a different tyrosine kinase inhibitor, we see it in the era where sunitinib and sorafenib are only available. We saw that those who are good responders, they respond very well to sorafenib in the second line, although we know the data of sorafenib in the second line is not that very impressive. But for those who responded very well in the first line, they do well on the second line therapy. So I think selecting a good tyrosine kinase inhibitor in the second line therapy for those who responded in the first line, I think it's a good option, and this will prolong the progression-free survival, and it will be additive value if you use the immunotherapy subsequently.
So nivolumab will not make its way to the front line.
Nivolumab, I think there are clinical trials ongoing using nivolumab in a different combination with tyrosine kinase inhibitors randomized against sunitinib. And this is probably will give us an answer, and this is a good combination because of the toxicity profile. So it can be manageable and practical to give patients for that, but the cost of that treatment probably will be very low.
I'm saying that because for the lenvatinib, I believe it will keep its position as a second line. By principle, the way it works, it will keep its place in a second line. Well, I believe it will not progress to the front line. But there's a chance for immunotherapy, for the nivolumab, to go for the front line, possibly in a combination. I do agree with that. Yeah.
Can I ask a question? Would your management treatment change for the pathology of disease, for example, biliary carcinoma? Would you treat it differently than yourself? How would you treat it?
Now, you know that there are different treatments, and there are c-MET inhibitors work very good in this category of patients. And those who has anti-c-MET treatment probably have the privilege of that combination in disability especially. I think the data for a first-line therapy, till today we have sunitinib. Because there are certain subset of patients, especially the expanded access data for the sunitinib included non-clear cell tumors, And as a first-line therapy, we still using it. And then if those patients progress, as a second-line, probably preferable to use the CMET for the papillary. For those who are sarcoma, probably chemotherapy, and different, depend on what is the run here.